Also are tasked with helping African Americans in the Gold Country region, and also Health Education Council has a Latino health project that actually also focuses on cessation. I'm not sure that they're here today, but they're part of our coalition. Oh yes, hi. Great. And then just finally, you know, I've already benefited from having been part of this Sac County Tobacco Coalition. You know, we have a cessation task force. We moved from saying we need to have meetings to say we need to go to the sites and help the sites. But know that this is a tremendous resource, and already, you know, thanks to the Sac County and other partners for coming to our Smoke and Tobacco Free Campus anniversary, helped with a lot of freebies and tabling. We rolled out a new UC Davis Emergency Department quit line referral protocol with the students who are there volunteering as research assistants. And then, I don't know if Danica, if you brought the quit kits.
I have 100 quit kits.
You have 100 quit kits.
Yes, I do.
Which, I mean, it's not very much, but it's just something positive when you give a smoker something to say, look, I'm just going to ask you to make a behavior change, and here's something to get you started. So see Danica about that. There's a picture on the bottom right about what that looks like. Okay, so next action steps, and maybe before we segue into the next part, just some key highlights to remember. If anything, the California Smokers Helpline, the 1-800-NO-BUTS. You may see commercials from CDC saying 1-800-QUIT-NOW. That's the national quit line, and anyone who calls the national quit line will get funneled to their state quit line, so no worries, but this is California's helpline. You can come learn more about our project. I think we're going to send around a sign-up sheet for finding out more, or technical assistance or whatnot, and a little survey about maybe what some of your questions or needs are, and our staff can help follow up. Would love it if we can have more folks at the Tobacco Control Coalition and more clinic representation. I think we meet bi-monthly, but at the same time recognizing everyone's time is precious. This is why we have a task force to follow with the folks in the clinics. And then how do we engage patients more broadly across providers, plans, and public health? I'm hoping this is our debut conversation where we can start seeing what's the interest and what are the resources for everyone to work together. So with that, I think I am going to pause there. This is, the supplement is, there's more about this supplement. There's a bit.ly address if you want to go look at that in greater detail. And here's some of our staff in the room, and I think we can follow up with the next part. Thank you.
I just want to thank Dr. Tong for her leadership. You've heard a little bit about it. She and I and Addie and this whole group training we built, we talked about what we're trying to achieve, and it's really what every session is trying to achieve, which is thinking about the outcomes, not just learning information and system approaches. Addie appropriately was jumping the gun, and RightCare got formed because if quality improvement were easy, we wouldn't have the dismal problem that really started us going, saying, how can we have 50% performance when other systems around the United States in cardiovascular disease outcomes are in the 90th percentile? So there's really no excuse for us in Sacramento County. We have a national expert here. We have the support of RightCare. We have the Sacramento County Coalition. We have the expertise that is literally ready on call to help out. So it's not just getting good information, but we cannot walk away as a group without getting someone else. Maybe your system's all set up, but there are refinements that can be done, and you need to customize. The reason quality improvement is difficult is you need to customize to the unique culture. People say, oh, well, Kaiser can do it. Well, anyone who's worked at Kaiser, I haven't, but I know a lot of people well who work. You can't talk about Kaiser North Sacramento and South Sacramento being the same Kaiser. They're different. So we have the expertise to work through the details, and in this last session, I want everyone to be engaged even if you don't represent a health system, because you can talk to someone else you know or gain something, and we need to get commitments. We're actually going to track this as an outcome. Who signs up for some technical assistance? Customized to your level, a baseline, whether it's, we don't know where to start, or we're well along on the journey, but we want to refine. So I urge everyone who can stay to, this is the most important part where we talk about transformation and getting the actual outcomes that we're all looking for, and it relates to reducing ultimately cardiovascular disease, morbidity, mortality. So with that, Elisa, I know your team has we actually are going to work through a real world situation, but that can be, learnings will apply, so.
Yes, and I think just because it's a big group and we just want to make sure we hear everyone's voice, I don't know if we could just quickly go around and everyone just say your name and where you're from or any thought about tobacco treatment. And I just threw up some discussion questions. So Dr. Baum's like a volunteer.
So I have a quick question, and it's, you have pretty good success with Medi-Cal with the incentive program for your no buts calling. And my guess is the small pink part of the bar, which was non-Medi-Cal. There's probably as many smokers non-Medi-Cal as Medi-Cal. Why can we not do as good a job in the non-Medi-Cal individuals as you're doing with the no butts for Medi-Cal? Should we get, especially since it's cost effective, you save money by stopping cessation, should we just not get the healthcare insurance providers in one room at one table and say, look, for a benefit, cost-effective benefit of $20 incentive, we want to roll that out for Blue Shield, for Health Net, for all of those programs. Here's the template to do it. Why don't we now use a successful program in Medi-Cal and flip it to the non-Medi-Cal population?
Yeah, I think that's a great question, and the helpline's open to everyone. It just happened that we were funded by CMS to target Medicaid, so yeah, depending on who we get in the room to
I think
say yes.
The key is incentives. Okay?
Yes,
you throw out an incentive and people will look at it and pick it up.
Yes. Yes.
No, I think that's right on, but it goes back to we're good. I think it is good just to quickly get around when it's the right time, as Dr. Ackord suggested.
Is this on?
Yes.
Yeah, so you talk.
It's funny when you meant. Do you want me to talk?
Well, Dr. Ivy did, but I was just reiterating that you said we need to know who's the denominator. So right after Dr. Ivy, Dr. Ivy.
Mine's pretty quick.
Yeah.
So you talk about the Medi-Cal population, but in our state we have a Medi-Cal waiver that allows us to have other kinds of programs under that, funding stream. And a big one is FPAC. We have a lot of young people who qualify for FPAC, family planning Medi-Cal, if you will. It only covers family planning related services, who would benefit from this. And if it's cost effective, why doesn't FPAC also participate, train people who are FPAC providers, and come up with a way for those patients to also receive the kinds of incentives and nicotine replacement and stuff.
Yeah, particularly with the effect on the baby and the developing fetus. That I think it's a great target group that Virgin Health does require any pregnant women smoking at almost kind of once they go to prenatal care or after delivery, kind of at least attend to it temporarily. But that's something that we need to drive as kind of the first target group, because there's another person directly affected with passive.
Well, definitely it could be part of preconceptive, care. Women aren't like just coming when they get pregnant. They're coming for a long period of time during which they are obviously reproductive age, planning their reproductive lives. It just seems like a place where there's a gap in the system not to have that integrated.
So during Mix, we didn't have the bandwidth, but WIC was one of our biggest promoters in LA, and Bimla Schwartz that's why we brought her on as one of our expert faculty for California Quicks, along with Patrick Romano and Olfat Sheikh. So I know Bimla is going to want to say something about that later.
Well, while you have the microphone, could you talk a little bit about the men-women difference that you're seeing in your data?
I can't recall in the mixed data if there was a huge gender difference, but I do know from the helpline, they do say women tend to call more, but I don't think there was a big gender difference for who was calling in the mixed project.
Or who's more responsive to the, who ends up quitting ultimately? Is there a difference between different ethnicities, different genders?
Right, and I don't think our randomized trials were powered to look at those subgroup differences, but those are very interesting questions for at the end.
So maybe Dr. Apgar.
Yeah, I'm sorry, Neal, I thought you said Apgar and you said.
Dr. Frank Apgar, yeah.
Yeah. In talking to what Dr. Swammer said, I agree that the health plans would drive this. I'd suggest that Neal and I worked on an AWARE project through the CMA Foundation for quite a few years, and collaboration is the key. We had health plans, public health departments, and all the provider entities across the state working together. They chaired steering committee, about 80 people or 60 people each meeting. But it was ongoing meetings. It was action-oriented of how are we going to make this work, and tie in all the different touch points in getting the providers or MAs or churches, whoever, are going to be touching the patient, the people, the members, the smokers, to get them to stop. The incentive programs, pros and cons. Health plans all have incentive programs for HEDIS measures for Medi-Cal and not Medicare, but Medi-Cal. And it's spotty, it depends. I mean, it really depends on the market, the degree of engagement of the patient, what they want to do. As a physician, thirdly, as a physician, I like your comments about the medical assistants. I think they're going to go a lot farther than the doctor. That being said, 42 years ago, I was sitting with Bob Brook when I was an intern at UCLA, and he met with all the interns. He said, population-wise, cost-benefit, everybody, there's only 2 interventions that doctors can do that are cost-effective in the overall time period. Stop smoking and wear seatbelts. And for that, I thought I'd go to medical school and 3 years more training to be an intern.
Full circle, right. So, Dr. Tong, Elisa, go ahead. Joe.
I guess I'll just take
Here,
it.
I thought you had one.
It's my understanding that one of the difficulties we face is that the amount of time that each plan will have a patient is still a factor. And not being a business person, maybe there's some people here in the room, has anyone come up with an idea of a funding mechanism that allows a previous healthcare plan, the current plan, and the future plan to share the risk, almost like an insurance plan or healthcare plans about that way they would have to own the problem for longer than just when that patient is registered?
I've never heard of it. Have you, Neal?
No, but I'm sorry. I didn't show one of the bullet points that I didn't talk about is that when there are environmental policy changes on smoking cessation, there can be a third reduction in just MI events in just a year. So there is a short-term. Your point is well taken that most people don't hold on to a patient for 5 years in a plan. But there's a 1-year immediate benefit. That's actually been replicated in several towns when they went aggressively community-based smoking. It's like the ED said, we're seeing a third less MIs. So, yeah, it happened in Colorado, and it was also I had another bullet point. It's been replicated. So it's not to take away from what Joe was saying, which is can we share?
Yeah.
We still need to talk about financing, but there is an immediate benefit, at least at the starting point. So, I didn't want to cut short the actual part on getting into working on that, and maybe I'll let you be the call. Maybe we can quickly get around so we know who the denominator is of folks, and then get to our actual case study.
Sure.
Oh, Addie said that might take a little long, so maybe we should go right into our actual case study.
Yeah, there are 50 people. That will take a while.
We'll come back and do that again.
All right, good. Yeah. Anybody else want to say anything before we?
I just wonder, we have Senator IPA with us and our former co-chair, Dr. Jose Revelo, who's been one of the big health information technology advocates in the state of California, if not the nation. And what you're talking about is really quite a breakthrough. So I'm just wondering whether you might be able to comment a little bit about how we can take advantage of this new era and your dream of what we can do with EHRs, Dr. Revlo, while you're here.
Connecting to the helpline directly.
Or I can also just jump in, and maybe Cindy can too, because we've been talking with Sutter about adopting the e-referral for Epic, and last I heard it was tied up in some legal questions, but I think it was about to get rolled out. So there's also
damn lawyers again. Okay, so use the free web portal.
I have to admit, even with UC, because we were referring to a sister UC, it was still a question of, well, who are we sharing information with? Who are we sharing PHI with? So we even internally, UC, we had to go through this whole legal counsel review. But I don't know, Cindy, if you heard anything else. I asked the helpline, but
I think they're doing it in pilot sites.
Pilot sites?
Pilot sites in Oregon, et cetera, et cetera.
Okay, yeah. So it's just maybe not a full-blown rollout.
So that's Sutter Medical Group and Sutter IPA, or?
Well, so Sutter Medical Foundation is really the overarching sort of entity that would encompass both of them, so, at least in the Sacramento region. But I think the point is an interesting one because, you know, there's an issue about the data exchange, which is one issue, and then there's an issue about referrals, which is actually a second issue, which goes into, you know, the issue of care. Data exchange is not necessarily care; it's just a process, and the challenge is more about the confidentiality issue. And so we've been dealing through RightCare. We wanted to create, you know, a system of exchanging data across the systems, recognizing that there was this wonderful opportunity in Epic because so many of our systems were in Epic, but not all, and then recognizing that there were other providers besides the large integrated systems that also were not going to be, are not and will not be on Epic, and how can we begin to change or identify ways to change the exchange of clinical information that can help us you know, do better care for patients at the right time. And then that would be the first step, and then we can tackle some of the issues like referral and things like that. Of course, whenever, I think you pointed to a really excellent Dr. Sky about when you start bringing in the risk issue. And as you all know, things are now moving toward, you know, the so fee-for-service type process into, you know, more kind of value-based, which is really risk, who takes the risk. And so now you try to figure out, well, how do you identify that risk and how do you separate that? So again, the big issue is the legal one that we talk about all the time that gets in our way. So we're still yet to kind of get to a point where we can actually separate those, compartmentalize those, and then address them in a really effective way. But I think there's some movement on it. Just this weekend, I found out that I thought that you know, even amongst Epic, we had it all taken care of, Epic to Epic, you know, it's called Care Everywhere. So if you're on one Epic and you, there's another instance of Epic, Care Everywhere, well, it's not as easy as I thought, because our competitor, Hill, has now put Epic up, and we just realized this weekend that, no, we haven't quite got it there yet, and so we still got a lot of work to do. So again, it's really trying to identify where those, you know, sort of barriers are, trying to figure out how do we, you know, overcome them so we can provide the necessary care. But I think we're all really optimistic that we're getting closer and closer. I don't know if that helped answer the question.
Does your EHR help you to understand the percent of patients that are smokers, who are on treatment, who are successful? Do you have a good database of that information?
So a couple of, so in an IPA setting, there isn't one EHR. So we do have a predominance, and we, you know, have Epic provide to those doctors that would be willing to accept it. But it's the old adage of garbage in, garbage out, and so it's really putting that data in to begin with and putting it in a way where it's a timely, you know. So maybe you had the data from 3 years ago, but it's the data today, you know, usable and that sort of stuff. So I think that's one of the big challenges is how do you do that, and how often, and how do you do it effectively so you can get the, you know, the right data. So that's a, and so when you say, yeah, it's there, you know, when you ask for it, and when you are able to refresh it in a way that is actionable data. There's a whole bunch of other social determinants of health that Neal knows very, very well, that we're still yet to find a good way to get the kind of data that we need that's timely, that we refresh us in a way where we can use it.
So a couple of years ago, Dr. Ivy from UC Berkeley and some of our colleagues at Sacramento Public Health and California Department of Public Health kind of mapped out where are the hotspot regions in Sacramento. And I'm just wondering, do you look at a zip code level and try to focus in on troubled neighborhoods on this?
That's a great idea. I don't think that we have, but we can follow up on that.
Martha Garrity, HealthNet.
Having just done a lot of community projects with Dr. Apcar and others, we've really established some big community-driven impact one-stop clinics with our partners like WellSpace, CARES, and others, where we're actually geo-mapping where those members live, who smokes, who smokes, who has high blood pressure, who has diabetes, trying to bring in people that have multiple measures in for a one-stop clinic. And a good example of this, there's a clinic, one of our clinics in one of my other regions, Stanislaus County, where in 3 months they closed 500 quality improvement measures with that targeted intervention. So that's really the way to know where people live, where people reside, and how close they are to their high-volume providers to really getting them in. I was going to go back to this commercial point of view. You know, we get the mailers, we get incentives, but is the incentive enough for someone to take time off work? We offered heavy incentives. We offered $50 for diabetes. We offered $25 for blood pressure. We offered $25 for cervical. We had people coming in for all three that had not seen a doctor in a long time to get all of those screenings done around Christmas time and walk away with a $100 incentive card. So it does work, but you have to target those members. And you have to telephone, get them in for transportation, etc. But I just wanted to share that because it was the best practice for HealthNet. And we do incentivize our smokers.
And I just want to build on what you just said about for people to take off time from work. That is a major barrier for people. So if we expect people to take off time from work, we have the wrong expectation. What we've seen in the highest performing medical groups in the state and country is that they have after hours care. They have evenings, weekends, availability. I'm not going to take off time to do those basic things, and neither is anybody else unless they're in serious pain.
So our clinics were Saturdays and after hours, and we got the providers, the Medi-Cal providers to work with us, especially the high volume clinics. They were really interested because they won, we incentivized our providers, we incentivized the members, it was win-win for everybody.
So can I see a show of hands in this room of people who are willing to go out to churches, senior centers, athletic events, other religious institutions on the weekends where people are gathered? You know, who wants to go out and do some volunteer work in spreading the word?
Well, Danica, maybe you want to say a little bit about what the county's doing, especially since we have this new youth coalition that's being built to help do outreach, and we had a Sacramento program also where the youth were doing a lot of this community outreach.
Let's do that in just a second. Let's see a show of hands of people in this room who are willing to help on the weekends.
That's Hattie at down the
All right.
In Sacramento.
In Sacramento.
In Sacramento. Okay, so we've got maybe 10 people in the room, and if you would just sign up with Megan and Brian before you leave, we'd like to take advantage of your interest in volunteering to tackle this hotspot in Sacramento. Highest rate of heart attacks and strokes of any metro area in the state, right here.
I have a quick question. So to integrate so I'm in quality improvement as well.
Yeah, if you would just say your name and institution.
Hello.
Hi.
Hello.
Much
My name is
better.
Laura Jackson. Actually, I worked for Kaiser for a very, very, very long time. I'm now with WellSpace Health in quality improvement. So we have a lot of smokers with WellSpace. We have a lot of plans and a lot of IPAs that we work with. So the idea of all the plans getting on board is music to my ears because that's part of our issue. We can have incentivized plans who, like Martha was just describing, that's great for their patients, but it's all different with each different plan and IPA. That's very challenging. So my question is, number one, this is another, how much would it cost? So there is integrating it into your EHR, which I think is a beautiful idea. That's going to cost something. Is that funded by the program, or is it just the program when once we're integrated and we refer?
Oh, so there's the low-cost, almost free version, which includes direct secure email, which some clinics have already done, like in Alameda, for example, Lifelong Clinic. And then there's the one where you ask the IT vendor folks to modify it to hook up.
That would be the two option. The second one, where you go in and do direct referral and dump back into the provider's inbox.
Right, but I think the direct secure email, one way is free. And
Thank you,
almost
Andy.
free,
Before you run
ways.
out, can we just ask the Heart Association, since the Heart Association is just leaving, you're probably covering this territory a bit in Sacramento. Can you just give us a 2-minute?
Oh, sure. So I'm the regional director for American Heart Association, American Stroke Association. I have, sure. I didn't escape.
You tried.
I wasn't trying. But yeah, so I'm a regional director here for HA, about 7 months in now with them. This is a great topic because we're talking about smoking cessation and social determinants of health. That's all coming out right now, so I'm seeing that come across my desk. So it's something that we certainly can try to tie in. And of course, we have a lot of volunteers, a lot of things that we do around, not just that, a lot of other things that we do. So we're there for you, and we want to be part of it. So is there any questions around HA? Or?
Are you doing anything out in the community with the faith communities, the senior centers?
We do have connections there. I have to get back to you on more specifics around that as I get to know more and more people within the organization. But certainly, we do have lots of volunteers in lots of different areas. So we'll definitely we can connect on that if you want, Hattie, and we'll get back to you.
Thanks, Andy.
On that. Sure. Thanks, everybody.
Okay, so then we were going to hear from Sacramento County, was it?
I've got one more question.
One more quick question.
Yep.
In my previous life, I was a physical therapist, and when I know a lot of physicians and orthopedic surgeons at the time would not do surgery, do an elective surgery on a patient who was a smoker. They'd have to quit smoking because of the comorbidities and all that. I'm wondering, are we targeting in this discussion surgeons who do elective surgeries who do believe this, who do believe, no, you have got to quit smoking before I do that total hip, or you have got to quit smoking before I even do a meniscectomy or an arthroscopic surgery. Is that something that's...
So is this something from Kaiser? Is Sutter doing this? Is UC Davis doing this?
It's not just
I've
Kaiser.
never heard of that.
You've never heard of it? Yeah, there's...
I've heard of that. Smoking per se.
Yeah.
Individual
surgeons
lower
the risk.
Because there is a high complication rate.
Yeah.
A lot of that. And I'm just thinking of other ways to target getting more of a, not just primary care, but all of us on board.
So I think that's one of the ways that you find champions. We talked about one would be an OBGYN or someone working prenatal care or through WIC. Another would be, see, we forget about surgeries only in primary care, but surgeons are another target. We just talked about oncologists now saying, oh yeah, maybe people being treated for cancer shouldn't smoke. And there actually is a policy on that, by the way, among oncologists. So I think any angle that one can find, you may find an orthopedic surgeon or, for that matter, a cardiovascular surgeon says we need to get you to stop smoking because you're going under a high-risk procedure. So anyway,
just thinking
that is a great idea. And after we answer that, I think there are a couple more comments. We're going to go into actual thinking through, because that's why this is what all improvement is, thinking through what the unique situation is. Or Sacramento County, we were going to.
What was the question again at this point? I think it's community outreach, and I don't think we have Heart Association at our coalition. We have Cancer Society, we have Lung Association, but I don't think we have a heart.
We had someone, I don't think he's with AHA anymore, so we should probably reach out.
Yeah, that's
That's why Hetty said hello.
Oh, Heart Association, please, you know,